So today I'm going to be talking about understanding acute exercise response among girls and young women with and without eating disorders. The objectives of the talk today are going to be to make a case for the study of in vivo exercise in those with eating disorders, to present some preliminary data on acute exercise response among those with restrictive spectrum eating disorders, and to set the stage for future research on acute exercise assessment and potentially in vivo exercise intervention. So we know that maladaptive exercise is present in the general population of adolescents and very common among individuals with eating disorders. Among the common definitional components of maladaptive exercise include feeling driven to perform exercise, having obsessions, exercising to reduce guilt or distress, exercising to prevent weight gain, and exercise leading to functional impairment. However, it's unclear which features are actually most salient to the reinforcement of maladaptive exercise, and little right now is known about the in-the-moment experience of exercise among individuals with eating disorders. So, why should we study acute exercise? So, momentary affect regulation is proposed as a driving mechanism of exercise symptom maintenance, and we also are interested in potential translational insights connecting biological and psychological impacts of exercise. But right now, there is not a lot of research on what individuals with eating disorders are feeling, thinking, experiencing during an exercise bout. So, understanding more about acute exercise and that acute exercise response among individuals with eating disorders has the potential to advance our understanding of this process, and also potentially the idiographic differences in exercise response across individuals. So we know, for instance, that not all individuals with restrictive eating disorders have this symptom of compulsive exercise, but some do really have this exercise-related feature. And could it be that exercise response and acute exercise experience is potentially related to this difference of individuals for whom exercise has this reinforcing property and really it can be maladaptive, versus those for whom they're less likely to engage in this maladaptive exercise behavior. And exercise in general is more likely to be a positive health behavior earlier in recovery for those individuals. And what this can do is also set the stage for in vivo exercise-based treatment. So we have different forms of, for instance, food challenges, food exposures, mirror exposures. So we have in the body image realm, in the eating realm, things that folks can do in vivo in the therapy session to aid their treatment, but we don't right now have the same thing for exercise. And showing that it's feasible and possible to engage in exercise assessment, and that individuals can kind of come in and do exercise in the lab could potentially help us to set the stage for these more in vivo exercise-based treatments. So I'll talk a little bit about the current project, and this project is a small pilot study that's designed to confirm the feasibility of exercise paradigms in evaluating acute response to exercise among outpatient individuals with eating disorders, and to characterize variability in biobehavioral response in lab exercise, specifically comparing eating disorder participants to those who are healthy controls. For this comparison, we're going to be looking a lot at graphical descriptions and effect size estimation here, because this is a smaller pilot sample. And then the second thing we're going to do is identify potential correlates of exercise response. For instance, the more trait level assessment of compulsive exercise, such as the compulsive exercise test or the CET. So to do this study, we have a fairly complex study designed across 3 different days. These days are randomized and counterbalanced across participants, and they include a self-paced task and a prescribed exercise task, both for 30 minutes, and then a rest condition for both of those. So on day A, individuals will come into the lab They'll do some state measures of affect and body image. They'll do a computer task where they're working for money, and they'll also have biomarkers taken. They'll then do 30 minutes of rest, have biomarkers taken again. After that, they will drink a milkshake, and this is designed to induce a little bit of negative affect, a little bit of body image challenge, and then have the opportunity to exercise for 30 minutes on a stationary bike in a self-paced manner, and we'll be assessing the heart rate, distance, kind of how they're choosing to exercise during that 30 minutes. On day B, they'll come in and do that same setup for the prescribed exercise task, but instead of resting this time, they're going to be doing that exercise. And our computer task, instead of working for money, they're going to be working for 3-minute increments of exercise. And on day C, they're going to be having that milkshake again, but instead of having the opportunity to exercise, just be resting for 30 minutes. And our pilot participants through September, we've enrolled 34 out of what eventually will be a 40% sample for this pilot participant. And thus far, we've had a low drop, so only one participant has dropped from the study. We have a 95% completion rate of enrolled participants. So a feasibility summary is that we've had strong participant interest and a 95% completion rate, and no concerns with completion of either the exercise or the food challenge task, and no adverse events. We have experienced some barriers, including some mild recruitment resistance from clinics, so we just had to make sure that we're ensuring that for the clinics that this was a safe and approved study, and that participants have reported some discomfort with blood draw as experienced or as expected. And there is a relatively high study burden with having to come in for 3 in-person visits, and those taking about 2 hours per visit. With regards to our pilot participants and their demographics, our average age right now is 19.1 with a range of 14 to 22. And the majority of participants report white, non-Hispanic, race and ethnicity, although we do have other races represented. We have 19 controls and 15 eating disorder participants currently enrolled. I will highlight here that the eating disorder sample, it's an outpatient sample, and so it's meant to be a slightly less severe eating disorder sample because we're specifically interested again in those individuals who are in the outpatient setting making those decisions about exercise for themselves at the time and how they make those decisions in the real world. The compulsive exercise test was our measure of trait level compulsive exercise, and you'll see on the bottom right that eating disorder participants are reporting higher levels of compulsive exercise on average, but not all are necessarily above the clinical cutoff. In fact, only 4 out of the 15 that have been so far have been over that clinical cutoff of compulsive exercise. When we're looking at exercise drive and response, the first thing I'll present is the progressive ratio task data. And the progressive ratio task is a task where individuals are working on a computer, and all they have to do is press the space bar. And the first 50 times they press the space bar in the first trial, they get a reward of, in the exercise condition, 3 minutes of exercise, or the money condition, $3. The next trial on each of those, however, becomes a little bit harder, so they have to press the space bar 250 times in the second trial. And then the third trial, for the next 3 minutes of exercise and the next $3, they have to press it 450, then 650, and that keeps going up and up. The break point is the point in which the participant decides, this is not worth it anymore, I'm done. And what we see is that the eating disorder participants are working a little bit harder and have a little bit higher break point in which they are willing to work for that extra 3 minutes of exercise, but a little bit lower than controls in the money task, so a little bit less willing to work for that extra $3. And the effect sizes across the ED and control are up there. Our Cohen's D for the difference between the eating disorder and control participants on the breakpoint and exercise was 0.46. Looking at the exercise parameters over the exercise sessions, so our eating disorder participants are always going to be in blue, our controls are always going to be in orange, and in the prescribed condition, looking at the percent max heart rate, the distance that they're going, and the effort that they're putting in watts during the prescribed condition, it's all the same. And that is good, that is expected, that is suggesting that our manipulations are working as expected. However, we see in the self-paced condition where they're getting to choose, okay, how hard am I going to go during this 30 minutes of exercise, the eating disorder participants are rising faster in their max heart rate and effort, and they are getting to a higher peak of that max heart rate and effort, and for max heart rate that's sustained pretty much across the session. Looking at affect, we see that the eating disorder participants start out feeling a little more crummy and fatigued and a little less calm and enthusiastic than the control participants, but that tends to converge over time in that eating disorder participants are feeling less crummy over time, control participants maybe a little more. Eating disorder participants feeling a little pretty stable in how calm they're feeling. The control participants are feeling less calm over time. And then if you look at the fatigue, you can see that it takes a little bit longer in the prescribed and the self-paced condition for eating disorder participants to feel that fatigue set in. Looking at just the 30-minute versus baseline and highlighting those effect sizes that are above 0.5, so in the moderate range, we see eating disorder participants looking at the change in feeling crummy and calm are feeling a little less crummy and a little more calm as compared to the control participants over that 30 minutes. Now, if we're thinking about body image and just kind of like how people are feeling about their body during exercise, overall, as we expect, the control participants are feeling better than the eating disorder participants about their body throughout the session. And that it looks fairly stable. We're not seeing any crossing of the lines there. However, if we look at the change across the session, we do see that while the control participants are not seeing much change in their body image during exercise, we do see positive changes for appearance, weight, looks, and even the average score in participants, and particularly in the self-paced condition, but also with appearance and weight in the prescribed condition as well. Now, moving on to associations with self-reported compulsive exercise, we see a little bit of a different picture. So across the compulsive exercise test total score, if we're just looking at that as a continuous variable, within the controls, the individuals who have higher compulsive exercise test total scores seem to be having a little bit of a higher breakpoint in that the exercise progressive ratio task, which is the dotted line here. But we don't see as much of a trend happening. In fact, for the eating disorder participants, there really isn't a relationship that stands out at all between the compulsive exercise test total score and their willingness to work for exercise. Looking at the average heart rate during self-paced exercise, we also see with the controls, there does seem to be potentially a positive effect. but not so for the in the association between compulsive exercise test total score and average heart rate during their self-paced exercise, but not so with the eating disorder group. And then if we break that out by people within each group who do or do not meet the compulsive exercise test clinical criteria, we see that only in the folks that don't meet that criteria do we see this big effect of the D of 1.12, showing that eating disorder folks are likely to exercise at a higher self-paced heart rate, even if they're not meeting that clinical, the compulsive exercise test clinical criteria. And then if we're looking at effort, we see a really similar picture here. So only among the controls do we see a positive association kind of start to stand out between compulsive exercise test total score and the effort resistance in watts. And we see, again, a similar picture with the change in body image state during exercise and CET total, and then diving deeply into the weight control aspect, so looking just at the CET weight control subscale and change in how people are feeling about their weight during exercise. The controls, we do kind of see in the prescribed exercise specifically, we see potentially a positive association between CET weight control subscale and feeling potentially better about your weight over time. But for eating disorder participants, it seems to be, if anything, going in the opposite direction. So our takeaways are that initial evidence supports that adolescents and young adults with restrictive spectrum eating disorders may be more motivated to exercise and choose to exercise at greater intensity. Affect and body image impacts of acute exercise are occurring in these expected directions in the pilot sample. And self-reported compulsive exercise aligns with exercise response among controls, but there's no initial indications of this same association with exercise response among the ED participants. And so there is a small n, so there's a couple folks with high compulsive exercise test scores who are exerting a significant amount of influence on the effect right now. But if this remains consistent, it kind of highlights maybe a distinction between exercise-related cognitions and this exercise behavioral response in the eating disorder population. So in some future work, we are excited to continue to develop and diversify the sample for inferential analysis in our upcoming R21 project and to examine the impacts of exercise on key biomarkers, along with defining these associations between biomarkers and these cognitive, affective, and behavioral measures. So many thanks to my funders, the study team, my mentors, and our recruitment clinics for aiding in this study.